On here. We'll call our workshop meeting to order. First on today's business is VI Health. Or Steve Mason, whoever's out there.
You're on the board of directors for
No, there were
Volume.
two out there.
The big.
I know there were two out there. Ron Shupin.
Folks, just come on in.
Whatever would you like, yes.
I'm right on
Anywhere
there.
somebody can take the podium
Formal
and,
work session.
Doing well. How are you?
How are you?
I am doing fantastic.
how you doing?
Hey, Mr. Osborne. Mr. Irwin.
Mr. Irwin died in '96. I'm here. John.
It's good to see you anyway.
It's good to be seen, to tell you the truth. Keeps my creditors happy.
Floor's yours. Y'all just go ahead and with your presentation.
So how do we do there? You queuing it up?
I've got you.
Perfect. So I just wanted to say it's glad to be here. Good to see a lot of you folks again. And just wanted to introduce, I'm Brian Shupin. I'm Brian Shupin.
May I make one suggestion? He may want to get to the podium. So that-
The video?
Yeah.
That's the only place we've got a microphone that can be picked up.
Hey, so I'm Brian Shupin, Executive Director of Community Relations for VI Health. It's good to see you gentlemen again, and I was thinking, and ladies. And I just wanted to introduce our presenters here today, and we look forward to a good conversation, answer any questions you have. If you identify any gaps or anything that we can do to partner with you to improve something in the county, that's what we're here to do. So we've got Rhonda Cox, Executive Vice President at VI Health. She's also the Chief Population Health Officer. And then we have Donald Roos. Our titles change pretty often, so I'm looking at the slide here. Senior Vice President of Provider Operations. What that means for Donald is he really puts all the services together. If there's any gaps for providers, anything creative that needs to happen, he's the guy that can do it. So I wanted to bring him today. Thank you.
Well, we appreciate the opportunity to drive up in a canoe. And then we got to the top of the mountain and the sun came out. So I think that's auspicious, and we were really grateful. It's nice to be back in Alleghany County. My goal is we're going to cover some high-level things that are happening in the system, some of which you probably know about, and then some of the things that are coming we've been talking with all of our counties around some of the changes that are happening in July and some things moving forward. And then Donald's going to zero in on the more specific things that are happening in Alleghany County and some of the kind of larger system level services that we have. So I always like to have my packet in hand, so that's the point of that. And again, my style is if you have a question, please feel free to stop me and ask as we go along. And but I'll move along pretty quickly because I want to save this is your time, and we really want to make sure we answer your questions. So that's my goal. And I am of an age. Today's my birthday, so I'm of an age. I'm going to wear these glasses with pride, and hopefully that we can do this. So the top page, if we go to the next slide, is really what North Carolina has said that their top goals are. I don't think this is anything new to anyone. I think most people can get on board with whole person care and really bringing the behavioral health system and the physical health system together for individuals who receive Medicaid or are uninsured. So I think we have always been a large proponent of that. We know is at the community level, if you take care of people holistically, they typically do better, and ultimately it benefits everyone. It benefits law enforcement, it benefits DSS, it benefits hospital systems, and certainly benefits the counties with the related costs that happen. Healthier people tend to be able to work and take care of their families in a much better way than when people are not healthy. There is a big focus on helping focus on outcomes, which we hope we're always paying for services that have outcomes, more focus on getting provider-based care management at the site of care, so helping people navigate locally, that kind of thing. And just in general, I think really trying to just get more, healthy North Carolinians, which I said before. So that is the piece that Dr. Cohen would want us to tell you about from North Carolina Department of Health and Human Services. If we go to the next one, let me tell you a little bit about what that means for Alleghany County and for all of our counties within Bias Catchment. So in July of 2021, which I cannot believe is literally just right around the corner, standard plans, so commercial plans like United Health, AmeriHealth, WellCare, are going to begin to take care of the sort of lower and moderate acuity individuals with Medicaid and behavioral health, and they're going to pull them into their plan. So today, VIA is responsible for sort of that wide array in our 22 counties, and in July, 80% of those people are going to go into another health plan. And that is happening across the state in every system. So they're going to maintain LME MCOs in the interim, and then only LME MCOs can apply for tailored plans in July of 2022. And for 4 years, tailored plans kind of have that captive market on that 20% that's left, and then they will open up that group as well to having access to commercial plans, can then competitively build for a tailored plan if they choose to do so. So what does that mean for Alleghany County? What that means is your DSSs and your individuals, your citizens with Medicaid, are now going to have multiple choices for where they get their care if they fall into this lower tier, which will probably be a little bit confusing for a while. For DSS in particular, they will carry the brunt of this just because they're sort of the front end and the front door of Medicaid around that. And it means that families are now going to have different options with these plans, and those plans can look slightly different in that. So we're getting ready, North Carolina is getting ready to undergo the largest change that we have ever had in the Medicaid space. Individuals who are uninsured will stay with your LME, so they'll stay with VIA, and then the individuals who fall in that upper moderate to more acute severe range will also be in that tailored plan at that time when it happens. At the same time, North Carolina is also breaking ground. The EBCI, the Eastern Band of Cherokee Indians, are breaking ground nationally. They are going to be the first health plan fully run by the Cherokee Nation or by any indigenous people, and they are doing that right now in our home state. So they are also getting ready to go live on that. And then the state is right now, today, as we were meeting, going through a series of listening sessions, and they are anticipating something called the foster care waiver, where DSSs and Medicaid and others are looking at if they're likely going to split out children and put them into the foster care waiver who are in that place. And the goal is, I think, to try to ease some of the challenges that DSSs may face, especially like if kids get placed, like they live here and then they get placed down on the East Coast, trying to make sure that there's continuity of care, continuity of services. So laudable goals, really complicated. What I would say to you, and the reason I'm saying that this is going to have a fair amount of bumps for different counties, is if we just did any one of these things in North Carolina, it would be a monster lift. But the amount of variability and change that is going to happen across the board at the state level, that's going to impact local county government, certainly the local county organizations, as well as regional local government like us, like the LME MCOs as well. There's just going to be very significant change, and I think a big part of our work together is to make sure that people can figure out how to get to where they need to go, how to get to the help they need like we always do, but also making sure that people know how to move between plans if they need a higher level of care. So that's a lot in a little bit. I know some of you guys know more about this. Commissioner Evans, you could probably do a seminar on this. I'm sure you've been in enough meetings in it. If we go to the next one, this is just really a high level. I spoke to this earlier about what folks can anticipate. So these are the numbers for your benefit, but this just kind of gives you a feel for what your communities can expect. So instead of having one, you're going to go to 4 standard plans. There's some provider-led entity regions And then there's the LME MCO system. So North Carolina likes to do it big. I guess it's go big or go home, but this is really challenging. And we talked about what a tailored plan is. So I'll keep moving.
Start to move.
Yes.
So that the in-between plans, there are some processes where folks can come back to our plan if they so desire, or if there's needs there. So we just want to let you know it's not going to be just, your social services trying to deal with that. We're more than anticipating a lot of challenges around statewide people transitioning to the new plan, 80% of people transitioning to the new plan, and maybe all the challenges that might be there initially.
Thank you, Brian. We've actually been working with our DSS partners, juvenile justice partners, our hospital systems, and really trying to be planful, because we know, even in the best planned situation, even with the most resources possible, when you're moving something that has this many moving parts, there are going to be places where people just they get lost in the system. And our job has been really to try to help support our community partners, as well as the individuals that live in this county. This is still our community. This is still home. So we want to make sure people get what they need and get where they need to go. How does this affect you guys? So right now, Alleghany County has a little over 2,000 individuals that are Medicaid eligible. And what we would expect, and so again, these are estimated numbers because it's only as good as the last data pull, roughly 1,700, 1,800 people will move to standard plan, and that'll leave about 315 to be in the tailored plan. Well, they'll stay with VIA before pre-tailored plan transition. So we will continue to support those 315 individuals. If the individuals that go to standard plan end up being more acute and needing a higher level of access to care because their mental health or substance use need has increased, or other significant need in that area, then there is a process, as Brian said, it used to be the raise your hand process. I think they've changed that now. But essentially, a person can self-identify, or a standard plan can identify a person and say, hey, we think this person actually needs a little bit more care. An example of that would be somebody that ends up in the hospital quite a bit. You guys actually have a fairly low utilization in your hospital, but because having a smaller hospital system, every person counts in those scenarios. So again, for us, that's really wanting to make sure that individuals who need to get into more enhanced, well-wrapped supports is going to be very important, and we're working closely with the state to try to make sure that people can move quickly if they need to and get what they need when they need it. I think that's our biggest concern, is potential gap in care. If I'm in a standard plan, I'm not doing well, I'm ending up in the hospital, I need more wraparound supports, I need different services, and then making sure they can get over to VIA fast enough to really get what they need and not kind of languish in that situation. So there's a lot of conversations happening at the state level, happening with the commercial plans, and happening with VIA to try to mitigate some of those issues. Next slide. All right, so this is the fun part. So that's kind of the high level. So now that I have depressed you a little bit with all the changes that are coming in it, Donald's going to talk about, I think, some of the things that have been working really well, actually, in your county, even through COVID and with all the changes and with some of the significant shifts. So I'm going to trade places with him.
Again, thank you for this time this afternoon, and again, we really want this to be a useful time. So again, please stop me if you have questions, or if there's something we're not covering, then definitely direct us to that as well. When Brian asked us to put together a presentation for you guys, we took a step back and said, well, if we were in your shoes, what would you want to hear about? And so we focused on what things were going on in the county, as well as things going on in the state. And then specifically, I'm going to share some data. And so it's easy for us to get up here and show some data to you on all the things that are going good. But we really wanted to show some data we're getting from the state on, where does VIA perform, based on where the rest of the state are, and where are areas we're looking to even get better on. And so in the first part here, I just wanted to touch base on the process of Daymark Recovery Services, which is the main provider currently in Alleghany County. Who are they seeing? What types of services are they providing here? So you'll see the split between indigent care and Medicaid services. And so as Rhonda said, that 52% of indigent care would continue to be the population that VIA would support in the county. And in roughly that 28% Medicaid, you can configure, a smaller portion of that will be ours, and some of that will go into standard plans. And so one of the things we've been doing with our provider network is really working with all our providers, making sure they are enrolled and working with these standard plans. One of the challenges in the systems is the standard plans are not paying the same rates that we do at VIA. So from the provider's perspective, they're not wanting to sign contract with all of the standard plans. And so if a member switches to, say, a United Healthcare plan, and our Daymark, another provider, does not have a contract with them, then that individual would have to go to another provider agency for their services. And so we're doing our best to work with our providers to make sure they're enrolling with those plans to cause the least amount of disruption to members in the system. And so we are working through that. We're really proud of that second bullet there. Daymark, as well as a lot of our providers, have not had any disruptions in services over this last year. We've had some providers, but through the pandemic, as you can imagine, it hit our system pretty hard. Our school-based services were in the schools, and schools were shut down. We've had services in jail systems that were impacted. Our residential treatment providers were significantly impacted around them being able to move kids in and out of services. We worked really closely with DSSs around this and kids going into foster care placements that really struggled through the pandemic. But through this in Alleghany County, there was no disruptions in services at Daymark. They continued to provide those services via telehealth and did not close their walk-in center to face-to-face referrals through the whole pandemic. That was done not by a lot of work through VIA and funding providers differently. And so we committed funding to our core providers and our walk-in centers to assure that those walk-in centers would not close no matter how many people walk through the door. And so if you can imagine, a business is only as good as the people that walk through the door and they can bill for. We came back behind that and supplemented that. So we made sure that those providers still received 100% of the revenue, even though the numbers of people walking through the door were dramatically decreased. And that's also because we didn't want to lose those staff. They're really hard to replace in rural counties, and so we supplemented funding around that. As you see there, Daymark received no federal PPP loan funding, and that's the federal loan funding that really helps support those staff for them to continue to meet those payroll costs in the system, and they did that largely because of VIA coming behind them and providing that supplemental funding to make sure that they could keep those staff and to keep those doors open.
Got a question. Did VIA receive any PPP funding?
We did not receive any PPP, but we did receive federal COVID funding from the state that came through the federal funding. And so overall, VIA received roughly close to $14 million from the state to support our whole system. And so we operate basically on a $400 million budget across our system. And so about $14 million of that we use to help support providers across the system. That in several forms. One, hardship payments to providers. We also provide higher rates in some instances to providers that need higher reimbursement rates across the system in order to keep them stable. All of our walk-in centers were in capitated funding, and so we maintained 100% of that capitation in those contracts in order to assure that their revenue did not drop, and all of our crisis and emergency services were 100% functional throughout the pandemic. So again, some quick numbers of the people they've seen. 273 walk-ins came through Daymark during the pandemic there. No were in crisis, whether they were routine, good numbers across there. And most of those all were diversions in the system. And so whenever someone walks into the office, they don't have an appointment, we consider that a potential crisis, meaning they felt like they needed to get some level of support at that time and felt the need to walk in and ask for it. And so we look at those and we look at how well our providers are doing and whether they're able to address that individual's needs, meet those needs, prevent hospitalizations, present any other crisis level services in the system. So you see there a pretty good turnaround of those 265 were able to get the support they need and return back to home with that level of support. So access to care. Put this one on here because I just wanted to really continue to make sure people understood our philosophy at VIA when it comes to access to care. Some people think that our services are just located in our 22 counties, and those are the people we contract and work with. Actually, that's not the case at all. We have contracts with providers in 84 counties of North Carolina. We like to be from Murphy to Manio, if you like that term, where we're looking to contract with all the providers that our members need to access whenever they want to access it. Of those, we have 1,195 specific site services in our provider network. So if a family didn't want to get services in Alleghany County and they wanted to go over to Winston-Salem, they wanted to go to Statesville, they wanted to go to Charlotte to get their services there, we have providers there that can provide those services. And we know sometimes people aren't comfortable getting services in their local community. They don't want their car parked out in front of the local mental health facility or the substance abuse facility. And so we specifically target all of our counties, making sure that we have providers in those, but also all the bordering counties and all the regional providers across the system to make sure that people have the access to care where they want to access that care in the system. And so you'll see there, this is a quick map of just some of the services, facility-based crisis centers in yellow. You'll see there that people can access those facility-based crisis centers all over the state in there, and some of our hospital units. On the previous slide, we talked about maximizing state dollars. That's a big piece of what we do for VIA, and one of the things we do, we get that money from the state, and our local communities, our local stakeholders, our counties are counting on us to maximize every dollar of that and spread it as far as we can. I think we all know there's not enough dollars in the state system to help everyone that needs the help at the maximum amount as they need in the system. And so our job is to maximize those state dollars and try to help as many people meet their needs as possible. So this is a statewide report. Just wanted to see where are we in maximizing the use of state dollars. And so you'll see there that VIA is currently ranked second, barely, under Trillium. That's our sister agency east over there. We're the Murphy analogy. And we're really proud of that figure that we're doing as good or better than most of maximizing those state dollars and serving as many people as we can with those state services.
If I could add to
Sure.
that, I think one of the reasons that's important is, as you guys know, in Alleghany County, we're spread out in our catchment. So most of our counties are rural, most of our counties are not population dense, so it actually takes more work. And Trillium is the most closely matched to us in the same type of small county to big county ratio. But we are the two most successful in being able to make sure that people get care, despite being really rural.
And a part of that is modeling out our services. As Ron the stated, is we have to contract a little differently in our areas than others in order to maximize that. We need to make sure that agencies are not opening their doors and closing the next week. There's some stability within those local communities. Hiring is more complicated for our providers in rural communities. There's just not a lot of social workers running around in some of our rural communities. Psychiatrists are hard to come by, and so as we get those, we need to make sure that they're stable and they're continuing to provide services in the community. So if you look across our communities, one of the things we do well is there's not a lot of provider churn, meaning that providers are going out of business, they're closing, new providers are opening. Most of the changeover in our network, when you look at it, has to do with mergers and acquisitions that you see in our system, where providers are consolidating to become bigger in the system. across the board. We see very few, unlike some other regions where they have a lot more instances of providers going out of business because they're just not stable, they can't afford to pay their bills. So another thing that we do really well, and I think that we really wanted to highlight here, because this was a conversation that we had with you the last time we were up here prior to COVID, is what are we doing to support law enforcement? Law enforcement, as you know, has had a really tough year, and we really wanted to get behind this. We pulled a lot of our services together, so wanted to show you a few of the services we're doing across our system to support that. So our law enforcement assisted diversion programs is something that we've implemented, and these are diversion programs at the law enforcement level with individuals that are using substances, where they can divert people directly out of their jails and into treatment services, and we have several of those programs currently operating in our catchment area. We've started several jail-based medication-assisted treatment programs. So if you're familiar with the opioid epidemic that's been going on for the last few years, we have a lot of individuals that are addicted to opiates and are ending up in our jails. And so in these particular programs, they're starting them on a medication-assisted treatment to address that opiate while they're in jail. And then as they're being discharged, we're connecting those people to our ongoing providers so they can continue in treatment. And what that does is it reduces those people showing back up in the jail, gets them back on their feet, it gets them back in their jobs, gets them back working with their DSSs to get their kids back. All those things that are critical for carrying on, getting their life back together, and making sure that law enforcement is not the bad person in that, but really the helping hand that gets someone started in the recovery journey. We also do jail-based assessment and treatment programs across our region, and that's what we're currently doing here in Alleghany County. And so, we've been working, with the sheriff and the deputies to develop the program. Daymark currently is providing assessment and treatment services at the jail. And last we checked on that was still going well and meeting their needs there. And so we do a lot of that across the system just to assure that people are getting access to those services starting in jail, and then making sure when they're getting discharged, they're getting connected back. So the majority of the individuals being discharged out of your jail are connecting back with Daymark, and Daymark's connecting them and making sure they're staying connected with treatment services.
And Donald, if I can just add,
Yep.
that was set up as a couple groups a week for local inmates. You house a lot of federal inmates, but for the very interesting jail, I enjoyed my tour of it. The left-hand side is your local folks for substance use, behavioral health group. And then I think a key point is making sure that they have a discharge appointment when they do get out of jail to follow up with Daymark or whoever the provider might be.
So, and lastly, the last bullet on here is another new program that we've started during the pandemic because we saw law enforcement was still needing additional support out there. Lots of conversation going on nationally around community policing, right, and around how we support police officers. Lots of models people are talking about, putting social workers in police cars, having social workers respond to 911 calls. Lots of models functional in a rural community when you don't have that many officers or a budget to put a social worker in every cop car or anything like that. So we designed a program for law enforcement called First Responder Rapid Response Programs, and we've utilized the benefit of the pandemic, which is expanded access to telehealth. And so we've started a pilot, and we've started it in Avery County, which is a sister county of yours, as wanting to make sure we did it in a rural community first. Because if we can perfect it in a rural county, we know we can do it just about anywhere. And so every deputy in Avery County right now has an iPad in their patrol cars, and at the push of a button, they can connect face-to-face with a mobile crisis worker. They can do evaluations in the field with that mobile crisis worker using the cameras of the laptop. They can do initial screening. They can help the officer do dispatch or disposition, meaning that if an individual needs to be taken to a detox center, they can help coordinate that for them. If the individual is just struggling getting connected in the community, they can help schedule an appointment for that person to show up at an office the next morning and make sure somebody's there waiting on them to get connected to the services. And so we just launched that in Avery a couple months ago, and we're working with them now to perfect it out. Avery County is probably very similar in Alleghany around the terrain, the lack of cellular activity in some communities, right? And so we're working through that and making sure that officers are well supported when they need to make difficult decisions of working with people with mental health and substance abuse and IDD. And so we hope to bring that to your community sometime soon as we work that out and approach your sheriff to say, hey, is this something that you'd be interested in?
I think a good so an easy transition here, and I probably shouldn't share this, but that was at no cost to the county. We supported, the training, the devices, training for officers, and Sheriff Fry, if you know him, is a great advocate for folks with behavioral health and substance use issues. And he's going to, really be our point person to tell us what's working well, what we need to critique or change before we can move it somewhere else.
That was one of our main goals there, is cost effectiveness, is most of our rural communities do not have the budgets to support a lot of these models being talked about, nationally. And so this was all about trying to provide that same level of support at a fraction of the cost in the system. So stay tuned around that one. Again, we like to talk about diversion a lot and what we're doing around that. And so I pulled this report. This is a report directly from the state that shows where is VIA at reducing people's wait time in the ED, meaning like how long are people in our catchment area sitting in an ED before we can get them access to services. And so this was originally put out by the state. You see there MCO A, B, and C. They didn't tell us who are all of the other ones and what their lines is, but we put down there we're MCO B. We know who we are, so you see there where that orange line and where we're at of reducing our ED wait times. And so as you trend out down here, out into April, you see we had a few high peaks in there, but overall we're doing a pretty good job of keeping people out of the EDs. On the y-axis there, you'll see there less than 5 days someone's in the ED at any given time. We have them back out in the community and in the treatment services. This particular graph was looking at youth because during the pandemic, that ended up being the biggest issue during the pandemic is youth sitting in EDs because they could not access residential treatment services, because if a residential treatment program had a COVID case, they could not accept any admissions. And so programs were basically shutting down all over the state. There was nowhere for kids to be admitted to. And so the state was tracking that, we were tracking that, making sure that those children were not sitting in those EDs and we were getting back out to where they need to be.
This is also relevant for you all as well, because you guys may know this, but when you don't have tons of complicated kids, but when you have them with your DSS, they are some of the toughest cases we see, because it's when they're bad, they're really bad. So again, I think our goal is to try to support Lisa and her team around really making sure Jimmy on site with Paige, with Daymark and some of those wraparound support. How do we divert children whenever possible? Because we know that's not the best place. A kid, sort of handcuffed in an ED room is not ideal. Nobody would want your kid in that situation. We don't want any kid in that situation. So we really push hard on that, and that's sort of, I guess, some of the data we'll show you here as well.
Mm-hmm. So again, we pulled some impartial data. We want you to see how we're doing in the system compared to everyone else. These are data that the state puts out. They track us on how well we're doing with people that are discharging from the hospital, meaning when those people get out of the hospital, are they connecting and are they getting the treatment they need post-discharge? So these are, the FUAD is follow-up after discharge, is what that acronym is. So we didn't have a lot of room to put that on there. And then if you see the DMH, that means those are for uninsured people. And so they track this measure based on mental health and substance abuse for those that are uninsured and those that have Medicaid. So the state can track and see if the people who are uninsured generally don't have access to as many options as people with Medicaid, as not only on the treatment services side, but in their own life, housing and other supports needing to connect with. So this is the follow-up after discharge measure for DMH. So these are for uninsured individuals, seeing where VIA ranks in that. And so you'll see there for the the mental health one, we're roughly at almost 50% of our people connecting with treatment services post-discharge in the system. The red line there is the target, the mark. State wants to see at least 40% of that target, and so we're well above that. As well as on the substance abuse side, we have 63.9% of that mark, and that's the only mark where we're not currently leading the state in our activity around follow-up after discharge in that particular measure. If you go to the next slide, you'll see this is our Medicaid averages there. You'll see that for mental health, we're seeing people on the Medicaid side almost 60% of the time, and for the substance abuse side on Medicaid, over 65% of the time. And so we've been tracking this really hard. We were the only MCO through the pandemic that did not drop below the 40% line throughout the pandemic. Of course, there's been fluctuations month to month. This is showing you an average across that period of time for the year. So part of our is investing in comprehensive and regional crisis services. So, what have we done to make sure those crisis services has stayed in place and we're solid across the system? We did increase funding to our mobile crisis teams over things. We know that numbers dropped off, calls dropped off to our mobile crisis team, and those are sort of, you get paid per widget you do, right? If you don't see someone, you don't get paid. We increased the funding to those teams. We actually have worked with those teams to increase the number of people with that, because we do expect as we come out of the pandemic, this is going to spike across the system, right? We're already seeing it in our child populations. There's a lot more encounters of mental health and substance abuse needs in our adolescent populations. It's impacting our families significantly. So as we come out of this, we're preparing for the spike, right? We're just not sitting there expecting the same old for the pandemic. So we're trying to grow that. We're trying to increase staffing in the areas that we know are going to see and be impacted by those level of services. We've expanded facility-based crisis services during the pandemic. A lot of those facilities had to drop back to 50% capacity because of social distancing guidelines by the state, so we couldn't have people in double occupancy rooms in there. So we've went back and we've configured that. We've been working to expand services at Synergy Recovery, which is one of your sister counties at Wilkes. And I'll talk about that one in a minute and talk about how that can impact you guys as a service going forward. And we've made sure that all of our out-of-catchment facility-based crisis systems are accessible across the state. And you saw there on the map slide, we have facility-based crisis units all over the state that we're accessing. We do things a little different with our FBCs. All of our FBCs for uninsured care have exclusivity to VIA, meaning that our contracts for those FBCs only allow them to accept those uninsured people from VIA Health in there, which provides greater access for our counties to get access to those local facilities. But we've also been able to contract with our out-of-catchment ones for additional capacity if ours didn't have capacity. So let's just say our Caldwell facility was full, we could direct an officer or someone else to the facility in Statesville. That one's not in our catchment area, but we have a contract with it, and we're able to place people in the Statesville facility because they may be closer for a lot of our communities. And we've also rolled out and continue to build emergency respite capacity, because what we saw during the pandemic, in a lot of instances, we didn't have a child that was suicidal or homicidal, needed to be in the hospital. We had some placement disruptions, or this child couldn't go back home, and they needed a temporary emergency respite stay. And so we've been expanding facilities across the catchment area to provide that emergency respite. allow them to be in a facility while we looked for the appropriate placement. We just didn't want to place kids in the next available bed if it was not clinically appropriate, even though we were in the pandemic. So we try to use these emergency respite beds to help to give the system a chance to breathe, sit down with the treatment teams and talk about what does these children really need to get wrapped around and return back to their local communities. And so we've also expanded that as part of our crisis system. So again, the Shirley B. Randleman Center, that's our new name for the Wilkes Facility-Based Crisis System. We spent roughly about $2.5 million on renovating that facility over the last year and a half. It's been a year and a half, maybe 2 years now, renovating that facility. It was a 14-bed, very old, outdated facility that probably not a lot of people would be proud of when they saw it before, and now $2.5 million later and a lot of work from local communities and individuals, and we have a new state-of-the-art facility-based crisis center in Wilkes County that's able to take mental health and substance abuse admissions from our mountain region out here. And that's really what we wanted, is try to get something in the mountains that we all could be proud of, and it's more easily accessed. That facility right now is not IVC designated yet. We are working on that designation. What does that mean? That means if an officer picks up someone on an involuntary commitment, they can take them to that facility and drop them off, and they can leave. They don't have to sit in the ED with an individual. And we know in our local rural communities where where hospitals do not have security or deputies, they're sitting in the ED, that's very critical for an officer to be able to do a drop-off and get back out in the field. So we're working on that rapidly now. We're dealing with the state, as you can imagine. That takes some time, and they have to do site visits, and during the pandemic, that has not been quick either. But we do expect that in the next probably 4 to 5 months, that facility will be IVC designated, and that officers from Alleghany will be able to drop individuals off at that facility without needing to wait. And we're hoping that that also is supportive of diverting people from your local ED as well, because it's a little bit further drive. If you add in the time that deputies are sitting in those EDs with people, you actually make that time back up overall. And then some of the work that we've done in the system for childs, we've recently concluded a great meeting with your local DSS around how things were going with them and areas for improvement, looking at services and supports that are available. And so one of our goals several years back with all of our rural communities is to make sure that our rural counties got access to the same high quality, robust services that even our more populated counties received. So this is a quick rundown of all the services currently available to your DSS and your child systems in Alleghany County. They get access to single point of assessments. That means we have a provider that goes to their office and does assessments for kids that need assessments. They don't have to send them down to Daymark. They don't have to send them anywhere else. Our provider shows up at DSS and does the assessments in their offices for them. We pay a higher rate for that, and that's because they are trauma-informed, clinically more intensive assessments. They give us a much better accurate on how we can direct the treatment for that child to get the best possible outcome with that. Access to outpatient therapy and psychiatry, that right now in Alleghany County is done through Daymark, but we are, like I said, supplementing them to make sure that they have access to child psychiatry, which is very limited statewide for Alleghany kids that need access to a psychiatrist, as well as outpatient therapists to meet their needs. We have additional, I'll just run through these really quick, but ask me if you want to know more about them. I could talk all day about them. But a service called TASK, Treatment Alternatives for Sexualized Kids, that may be coming through the system. That service is available in Alleghany County, provided by Children's Hope Alliance. Intensive in-home services, those are therapists that are going into individuals' homes and working with families in the local community. Multi-systemic therapy is also available in Alleghany County. That's specifically for kids that have conduct-related disorders, kids that are more likely involved in your juvenile justice system would access that service. Transitional youth services, which is one that our board heavily invested in several years ago as community reinvestment. These are for kids that are aging out. So these are your 16, the 25-year-olds now in that range that are aging out of the child system and that are going into the adult system. This services comes in and really wraps those transitional age, older kids with the supports they need, connecting them with community colleges, connecting them with work, all the things they need to be successful in the community, because we see high prevalence rate with that population of those individuals being involved with our court systems, our juvenile or our legal systems, being more involved in domestic violence issues, more instances of being involved in substance uses. So we really wanted a strong focus on those transitional age youth, and that service is available throughout Alleghany County. And then what we've invested recently, and I'll talk more about it in a second, peer and family support partners in Alleghany County, and expanding that, making sure families have access to those. Emergency respite, as I talked about. And then shared case staffings is something we do a lot of in Alleghany County. Our care managers, as well as our providers, are sitting down at the table with your DSSs, and they're talking about cases and kids and trying to figure out what's the best way to support those families. And when I mean that, I mean families, because we really have to look at the whole unit. And so, we're getting those providers and our staffing at the table and making sure there's a good plan in place for that.
One of the other things to know about the case staffings too is they'll work with your DSS team, and then they actually, inside of VIA, there's a multidisciplinary team that goes all the way up to my level, and in some cases goes all the way up to the CEO level when we really get stuck. So when Jimmy is working on it, and I see this happen all the time, when Jimmy Poplin, who lives here and works with your DSS, we have one of those really, really hard cases. A lot of times they're running those case staffings inside of VIA at 5 and 6 o'clock at night. And if they're stuck, I'm chiming in and saying, hey, we need to do this, or our chief medical officer's doing that. So we've gotten, this is something that we learned over time. VIA started out as Smoky. We started out in rural counties, and one of the things we heard over and over again was the concern about little counties worried a lot when like Buncombe and Henderson came on. They were worried about getting lost. One of the commitments we made really early was you're not going to have anything less than the biggest county. We are going to figure out how to finance it. And then the other thing we did really early on is we co-located staff inside of DSS. So, I've got staff that have been in DSS buildings probably 12 to 15 years. The state is just now saying, hey, we want to do that in foster care waiver. We have made that available for every one of our counties since our inception, since we really started that. And I think what we've learned about that is you can't solve every bad situation, but you can figure out how to make the best of it. You can figure out how you don't leave your partner in the lurch. We stay with it. We stay with the kid. We stay with DSS until we get it figured out. We figure it out. Donald is wonderful about calling the providers and saying, hey, can you just do this one thing? Can you be creative and help us do it? We figure out the financing for it. But I think that's one of the things that we've learned is it has to go all the way up sometimes to the executive level, because we're the ones that can write the check. So, if we can say, yes, we're going to make an exception and make it move. And I think that to me is probably one of the best things we've done for making sure our kids don't get stuck. I mean, it's never fast enough, and COVID made it really hard, really, really hard this year. But it has enabled us, I think, to get kids in places that were better for them so that they could stay home or get back home faster and not get stuck in these institutions way down east, which I have really strong feelings about, which I'll share to you. But.
Well, and I think just one thing to overemphasize is the co-location. It's offered to every DSS director. It's really their discretion if they want that, need that level of support. Some places we're there every day. Some places DSS director says, hey, I just need you Monday and Wednesday mornings. That's when we're seeing certain kids. So we're more than willing to do that if the county's got space or just a visitor's office that staff can go in and work. And we found counties that's had lots of challenges around moving kids and navigating the system. if they could just go right down the hall and ask someone in VIA, hey, how does this certain process work, or how can I get this kid moved quicker? That's been very helpful.
Makes all better.
And again, a couple of things we're working on. I mentioned it before around peer and family partners. VIA recently received a 5-year system of care grant, $4.9 million, and hopefully you guys are aware of that. Alleghany County is a part of that grant for us. That was through SAMHSA, and that is for us to expand peer and family partners in Alleghany County, as well as 7 of our identified counties that are part of that grant. And that's all about making sure that as families enter the system, and any time a child has to be removed from the home, we immediately are working to assign a family partner to that family to support that family and continue to prepare for that child to come back to the home at some point. And likewise, we didn't want the child to get lost in that mix either. So when they're pulled out of the home, they get assigned a peer partner that stays with that child no matter which provider he's with, no matter which services he's in. That peer partner never leaves him. It stays, provides that connectivity, and continues to provide that trust, because what we see is that that child can, every time a treatment change happening, that trust is broken. We introduce more trauma into that child, so we really wanted to create some stability in that treatment system for that child and for that family. And so the grant's looking with that and expanding that. I think, help me with this, Brian, I think we have 4 members on that governing board for that grant that are either in Alleghany County or work with Alleghany County on implementation of that grant. So you guys are definitely well represented at the table for the implementation of that grant, and we're really excited about some of that work.
That's 7 of our 22 counties as part of that grant. You might have mentioned that,
Yes.
Donald. So 7 of the counties, your neighboring counties, Ashland, Wilkes is part of that as well. And Lisa Osborne knows lots of information about that. Obviously, it works closely with kids and supports for families.
Then you may or may not be aware, the federal government's also changing the landscape on us while the state's doing that. There's a Federal Families First Act. You may have heard of that, where it's going to really change the landscape of how child residential services are provided. So VIA has been trying to be real proactive in that conversation and trying to prepare our system for those major changes that are going to occur this October, which is another thing that we could definitely put on our timeline in our conversation for us. And so we've been out there working to redesign some of our residential services to prepare our providers and our DSSs on those change. That federal guidelines are not going to allow us to keep kids in residential treatment facilities for long periods of time. That time's going to shorten, and there's going to be more need for us to use our foster system to better support families. And so you see here a few programs that we've started in our catchment area, and we'll be bringing across there. All of these, or most of these, are accessible for Alleghany County. We've developed a specialized therapeutic foster program for kids that are on the autism spectrum, and that's making sure those families are trained to work with kids on the spectrum. They also are getting a service called Applied Behavioral Analysis, which is the best practice for kids, and those families are being supervised in that. We brought a new model to North Carolina called Therapeutic Foster Care Oregon. Has Oregon in there because it was first developed in the state of Oregon when Oregon removed institutional care from the whole state. And they used this service as a way to do that. And so VIA has brought that service to Western North Carolina and to our communities, and we're rolling that service out now and beginning to recruit families to provide that level of care. We also have a program called the One Home Pilot that started in rural County as well, Cherokee County, North Carolina, where we're working with braided funding with their local DSS to basically, our goal is to make sure a child is only placed out of the home one time, meaning they don't change providers, they don't get moved from families, they only have one experience. They go into a foster home and they don't move. And so our goal is, no matter how acute the child gets or no matter how intense their needs are, we do not move the child from the home to get those supports. we push all of the supports into the home and the family. I know that's a novel idea, but that's, when you really think about it, it's harder than it sounds, but it's really the right thing that we should be doing for family and kids. And so we're piloting that now. State DSS is at that table as well. They're looking at what we're doing as this being a potential model for the whole state to potentially adopt on how we're doing this in Western North Carolina. We've developed assessment centers for short-term assessment for kids in our area to get them assessed and then meet their needs and back into their communities. We've done Reuter Transitional Cottage, which are rapid short-term beds in our area for kids. And then we are working on one thing as we did our discussion with all of our DSSs as well as yours is like, what is your greatest need? Like, what do we need to be doing? How can we best support you? And across the board with all of our DSSs, where they said they need the most help is recruiting foster families to help with kids. And so we're working right now on creating a network-wide recruitment campaign to collaborate with our DSSs and our treatment providers to do a recruitment campaign and try to get more foster families into our systems at the local level so we can keep kids closer to home. Next. And also just touch base on this. This is another area that we do really well at. Looking at state data, state recently came out with a report. We had it on here originally, but it was just a bunch of numbers, and we're like, this is just really hard to read and understand, so we tried to boil it down a little bit with that. And this is looking at individuals that are placed in what we would call institutional care that have intellectual or developmental disabilities. And so right now we have 26% fewer individuals than any of our neighboring LME MCOs that are in institutional care that's either at the ICF level, which is intermediate care facilities, or state-operated facilities. And so we've been working really hard over the last few years to keep individuals out of institutions. And so those are your state institutions. When you think about that, that's Riddle, that's in Morganton, Murdoch, Caswell, thank you for all those. And trying to just, if an individual needs to go there, we try to really keep that time as short as possible, get them back to their local community where their local support system is. And so we're really proud of that number, continue to work on that. Our goal is to not have anybody in institutional care that has IDD. And so that's our goal, so we're pushing for them, and that's part of our mission. And lastly, I think, Ron, I'm going to hand it back over to Ron to kind of wrap us up and talk about meeting some local needs in our system.
So you can probably see a theme. We have a real commitment to, we believe people are best served in their communities. We want families to stay together. And we don't want people, unless absolutely necessary, we want to try to keep people out of institutional care. So this has been kind of a large progressive push, I think, for many years in that. And so we are grateful because we can't do that without county partners who are on board with the belief that families are best served at home, regardless of age or disability type. So lastly, training. So this is something 30 in Alleghany since 2019, despite COVID. So I'll point that out. Continuing to do a lot of work. And then based on data that's been provided from Brian Shuping, his team, and others as we assessed needs from different county agencies, one of the areas that we know we're going to be, several of the areas we know we're going to focus is around youth mental health first aid. Sorry guys, I guess I'm getting to the afternoon where you get kind of tired and your brain and your mouth don't keep up with each other. But youth mental health first aid to really help reduce suicide and really address the risk for suicide prevention. Wellness recovery action planning, which is available both for children and adults, but really helps people sort of be accountable and figure out what works best for them and how to be stable and what they need if they know they have a mental health need or a support piece, and they help figure that out ahead of time. Counseling on access to lethal means, you can probably figure out what that means. And then the QPR, question, persuade, refer, suicide prevention. So a lot of these, one of the things we have seen, particularly with COVID, but also just I think in general, is you see spikes in suicide, and particularly we know that's one of those things that if you have one suicide, it can directly impact the well-being of all of those in that inner circle, because it tends to kind of spread in that. And so we know that this has been a key issue and a request from Alleghany County, as well as some of our other counties that are very invested in making sure that we're doing all that we can, both to support youth and adults who are at risk. We fully anticipate, we're following the national trend. What we see is that as people are starting to kind of get out a little bit more, we're hearing more and more about people's anxiety level, depression levels, and we've certainly seen in the call center, our 24/7, 365 access line, less calls, but the intensity level, when people are calling in, they're in a really different place. And a lot of that has to do with, you guys know as well as I do, is we're not made to be socially isolated. And a lot of people's resources and supports were shut down. And so when you don't have access to those traditional supports and that face-to-face, and feel like it impacts all of us. And if you're already struggling, it only kind of exacerbates that situation. So you guys have been really patient. We wanted to share what's going on in terms of some of the things I'm sure some of you knew about, but you may not have known about all of them. I think the next thing we'd really like to do is just hear from you around, is that working for you? Are there areas that you see that we need to work better? We try really, really hard to say, hey, we heard you, and here's what we did, to try to meet that. I think that tends to be our style with you all, but I want to make sure, because it's easy for us to come in and be like, oh, it's wonderful. And I think, again, we would want to hear from you. It's important to us that we're meeting the needs of the community, and would want to make sure that this is matching your experience and what you're hearing as well from your peers and colleagues that you represent, and certainly in supporting the members of your community.
Commissioner Luckman has some questions for you.
Yes, I'm a licensed CSAC. I'm a former employee of Daymark. I was a probation officer, and I worked for the Old New River. So I've been around the block.
Yeah.
So I've worked under, pre-LME and after, and dealt with both sides of the table. So
Me too.
Anyway, I just feel like that we have a lack of service here. All these statistics and all these things are great on paper. But, the facts are that, when we have someone that goes into foster care here that doesn't have an in-home placement, they have to go to like a level 3 or a level 4 placement. They're having to go out of state. And that's ridiculous. I know a kid that had to go to Rock Hill, South Carolina and stay in foster care. And, I just don't see that, we should be doing that to our local kids that are taken out of the home.
I agree with you, actually. So you are absolutely right. The piece about the foster care in particular, I think, has been a huge issue. And there's two things, right? One is we pay for therapeutic foster care, and then there's foster care on the DSS side. And it's a split system, which is really not working well. And to your point, I think that's exactly why when we went back to our DSS teams across the VIA catchment, we're like, guys, this isn't working, and we hear you. So we're doing two things to try to address that. One is, when Donald mentioned like the one home pilot and those things, our goal, now we're within the context of Medicaid because Medicaid's the payer, but our goal is to try to get rid of this artificial delineation between foster care and therapeutic foster care. Because here's what happens. A kid has to meet something called medical necessity for therapeutic foster care, which means according to Medicaid, that kid has to hit a certain level of acuity to get that special service. So a kid goes to therapeutic foster care, they start to get better. Guess what their reward is for getting better? They don't meet medical necessity anymore, so then we have to move them. And it's the way the system is set up for that. And I think we all recognize that is not to the benefit of children in any way, shape, or form. So part of the reason we're trying to push the envelope about can we take care of kids in foster care and then wrap all of those supports around. Medicaid today is not set up to do that. So we are working with the state to see if they will give us sort of special I don't know what the right word is for that, a special allowance to be able to do that. And then if we use braided funding, it allows us to be able to navigate and move between the regulations that we have. We have a secondary piece in place as well around working, he mentioned we're working on a much larger, or Donald mentioned a much larger kind of systemic piece about how we can do a more aggressive foster care recruitment campaign. All of that is in service to trying to get the state ahead of foster care waiver. Whether or not VI gets the, we certainly intend to apply for it, but whether or not we get it, we're going to try to do what's right for kids regardless of that before that ever gets here, because of exactly what you said. I think with regards to level 3 and 4, COVID, it's challenging in general to get kids into those places because there's just so many children kind of pouring into institutional settings. But what we saw was they would cut capacity. They went down to 50%, and then we got into situations where there were basically no takers. Again, all of that is they'd have an outbreak inside the unit. They couldn't take any children. It would stop all admissions in that, and then you're just trying to scramble about what's next closest. You may have noticed I was a little bit passionate about the kids stuff. I worked, before I came in here, I worked in the state hospital system, and then I worked in the state prison system for 6 years. And what I heard was I got to where I could do an assessment blindfolded. I could change the gender and the color of a person, but I could basically start telling you that between ages 8 and 9 years old, they started going into our residential facility system, and they never got out, and they pipelined right to prison. And I worked with youth back in the Western Youth days. I worked in 4 or 5 male facilities, medium and close custody, and I worked in women's prison, and it was the same over and over again. So when we got to VI, I think one of the commitments that we've made, and we have been steadily pushing this, and our chief medical officer is very much on board, is to the degree we've got to treat families. And so that's easy to say. That is not always easy to do because sometimes families don't want treatment in that. But I think we're trying to balance the scenario, again, of where can we have these really aggressive kind of high-end, high-intensity community-based placements and care and get them home. So that's why we have things like the Elida Center to try to divert what you're saying is because a lot of times the family's blowing apart. The kid does need somewhere to go. But it's not the kid who's got the main issue in it. And it's just trying to have enough capacity to do that until we can legitimately start shifting more and more children out of the level of residential 3 and 4 in it. We will always have some level of residential. My personal preference is that there would be probably, well, my personal preference is we'd be like some states that don't have them, but I'm not, technically it's required in North Carolina, and I don't run the show. But I think the minimum possible kids, only in the most extreme cases, and only for very short duration. So we've been steadily pushing our numbers down across the catchment for the number of children. Any of VIA's kids, if you look, you would see a pretty significant downward trend in that. But you're absolutely right. They shouldn't have to go out of state. They shouldn't have to go across the state. And I don't want to build a state foster care plan where we're planning for having all these all these network agreements down east, because if the kids from here, that means you've ripped them out of school, you've ripped them away from any kinship. Nobody can do family treatment. You can't do family care. So I agree. We're working on it, but it's been slow progress, and I don't want to waste another generation. I feel really strongly about that.
Next thing is hospitalizations. It seems like they last forever around here. It's not uncommon for somebody to go in our ER and stay there for 30 to 45 days before a placement is had, or they ask them numerous times a day, do you feel like you're going to harm yourself or someone else? And when they finally say no, they send them home sometimes. That is not helping the whole person. And, you talk about how there's synergy beds. I like to know how many synergy beds the Alleghany residences have actually gotten to go to, because it seems like that when I was over there, there was never a synergy bed available for anybody. They were all full from Wilkes and, Surrey and different places. So, it seems like our services over here are very, very limited. You have group therapy. You have telemed with a psychiatrist about once every month to 6 weeks. You have a few groups that are available, and you have PSR. But, you know, the things that really make a difference, like ACT team, we don't have. You know, we don't have mobile crisis over here, or we didn't. I don't know if we do now. You don't have intensive outpatient. You don't have case management. You know, those are the things, individual groups for kids, you don't have that. And to me, those are the things that really make a difference in people's lives that have been cut out. And I know the staff over here is very limited. They do what they can with what they have, but they're basically a skeleton crew over there. But I feel like we, as Alleghany County, are kind of getting left out because we're not getting all the services that all the big cities and all the bigger places are getting. Like, I'd like to know how much of your statistics are actually for Alleghany County, but not your entire group. Because I think that's a fair question.
I do too. And we're happy to
And-
get you that.
And I just feel like, and I know that when I was employed there, I felt this way too, but as an Alleghany County resident, I know that our people are getting left out. And we do not need to be getting left out just because we're a small rural county. We deserve the same services that other places do too. Just because we're small and we may not generate as much billable time or money, it doesn't matter. You know, we have people here that are committing suicide. We have people here that, you know, just live on the edge all the time. And we're just one small thing away from having a major, you know, catastrophe, like you hear, you know, a church getting shot up, or, you know, a workplace getting shot up. You know, it could happen here just like anywhere else, and we need the services here to protect our people and to help people out. You know, substance abuse, people might go into a substance abuse treatment and they come out and they're sent to like 1 week outpatient or 1 day a week outpatient. You're never going to stay clean like that. You know, you've got a serious drug problem. You can't come out of, you know, a 30-day treatment or whatever and just go to a 1 time a week group and expect them to stay sober. So we need more services up here to help our people.
Definitely hearing the piece about the adult services. Brian, I saw you wanted to step in and didn't want to interrupt.
You're standing behind the mic, so I probably shouldn't be talking, but thank you, Commissioner Luffman.
The public is not going to be able to hear a word you say until you get up on that mic, please.
Okay, I'll step.
I'm sorry, I'm very passionate about this because I've worked in this and I know.
Absolutely. Thank you, Commissioner Luffman. That's great feedback. And Rhonda is really more appropriate to address most of those. I was the project manager at the Synergy project for 2 years. I've got a few gray hairs from that, but it's a great facility. Prior to us making that investment, they contracted with Cardinal and Partners, so bed availability was really difficult. Now they're exclusively with VIA. I think Donald had shared we have the most facility-based crisis beds in our catchment out of any MCO, and we've asked them to give these former 5 counties priority because it is a regional facility for admission. So if something's sitting on, admission comes in from Caldwell County and admission comes in from Alleghany, if Allegany's appropriate, they should take that individual. So I just wanted to, you had several other things. I'll let Rhonda to address those, but I just wanted to mention that. Yeah, they just recently reopened, great facility, and I think it's something that folks will really get some real benefit from. Working towards the IVC designation, what we hope is Sheriff Maines here and Chief Deputy Hawks can bring folks there, do a quick intake, 20-minute intake, and leave. You know, and then be able to help folks get back home or however we get that organized. So we knew that was a real need here. I know Commissioner Evans came to the groundbreaking ceremony, and we recently just had the ribbon cutting. But we hope that'll be a real asset for this area. Thank you.
Let's talk about mobile crisis because I do think that's important. So if you are not getting access to mobile crisis, we need to know that because you do have mobile crisis as a service in your area. So talk to me a little bit more about that because that is something that we can remedy.
It was just my understanding that we didn't have an ACT team now or mobile crisis.
Now, you have mobile crisis. All of our counties have that and have access to that. I know there can be, so I do know sometimes frustrations can be about the length of time between response time. So I think if that is an issue that you guys are having in your county, we are the right people to tell that to, and that's a conversation that we'll be having with Billy when we go back in terms of that. I'm trying to dig through my brain banks. I'm sorry, on the Act County and the Act,
They should have access to act if they're not getting that.
yeah, and so when you said that, I'm like, that doesn't make sense to me, so I was trying to think, did I miss something in that? Yes, sir.
Now, one of the complaints that I've had, or I should say, concerns, is on the mobile crisis team, whenever we have an individual that they feel needs intervention, the mobile crisis team is a phone call or telehealth. And I agree that a telehealth or a telephone call is not going to be able to properly assess the individual. Now, whenever, that's words. Let me tell you my background. 1973, my wife was in a car accident in Mount Airy, 4 months pregnant. Took them an hour to cut her out of the car. They could see the hospital. We didn't think that child would make it. We were waiting for her to lose the child. The child was born, even though for 2 weeks we had no fetal heartbeat. At age 14, that child had attempted suicide 7 times. She had attempted to kill me 3, her mother 4, her grandmother 4, and she was institutionalized until she died January 27, 2019. The biggest problem we had as a family was getting care for that child. We could get her into any institution. At that time, Champus paid for 90 days. At the 89th day, I don't know how many times we would receive a phone call, she's cured, come and get her. Alleghany County has one of the highest per capita suicide rates in the state of North Carolina. It kills me every time we lose someone in this town. Now, if you've got a mobile crisis team, they need to come. They need to be able to look at that individual and assess the body language. You can't do it over a telehealth, a teleconference, or a phone call. Now, this is where we're begging. Come help us. We've got problems here. Now it's beginning to warm up, so our transients are going to be coming in. The drug problems that we have, or people in this county don't know. The former Parks and Recreation director that we had, every morning she went to the Veterans Park so that she could pick up the needles. Putting out the lights at Christmas in October. They couldn't go into the bathroom because on 2 occasions, the people that were working over there in the farmer's market opened up the door and somebody's shooting up. You go to our outside facilities, you look up in the rafters, sea bags up there, people's clothing where the transients are over there. We don't see them that much here. Pulled out in the street last year, and there's a young lady, very nice looking young lady, pulling a suitcase, completely out of it. Somebody had dropped her off because she was a crack whore. It took them 2 weeks to get her off the streets here because they had nowhere to put her. We talk about youth. That's a fine example. Whenever you've got someone spaced out walking down Main Street, pulling a suitcase behind them, using language that in 26 years in the United States Marine Corps, I probably heard some of it. I mean, we are small and we're poor. And it may be something that is true or not true. Maybe we are just have a complex and we think that because we haven't got that many votes, people really don't care about us politically in Alleghany County. But we have needs, and we would like for these people to take care of. Last suicide in this county was by a 15-year-old. His father had to break down the door to get into it. Father heard a shot. I know how that affects people. I've been through it. I had one of my men committed suicide after I chewed his fanny out. I've hold that because I don't know if I said something that set him off or what, but he's just as dead. I understand, and I've been through the system, and I've been chewed up by the system, and I know where you're at. I've worked with government. You're limited to the rules and regulations that they're going to lay upon you, and they're written by a bureaucrat that has absolutely no idea what you're going through. But, you know, we would love consideration.
Well, I think you're absolutely right. You should get consideration. I think the other thing is Alleghany's you're not our smallest county. And so I think and I want you to hear that because the reason that's important is that's exactly why I think we made the commitment that we did around really, not just talking, really trying to ensure that there are services and not making people fail up. And you guys, you're right. There is no perfect. We're going to battle that, and we will battle that in small counties, and we always have. I think the commitment that we have to you is you've told us this, which I think we do try to check in. We have folks that sit on our cab. We have Allegany's represented in our County Commissioner Advisory Board, represented on our board. You've given us this information. I think the thing, so what we need to do is put legs on it. I can't solve that lady walking down your street today, but what I can do, or what we can do, is I think certainly with the Mobile Crisis in the Act, that is something we can. Tell me about IOP, Donald, because I think that's the one, I know that is the harder one to do in small counties, and we have wrestled that bear for 15 years or more.
In all of our contracts, we contract with our providers to do IOP. Now, based on whether they have enough numbers in those IEPs, sometimes they'll move to a group outpatient model.
I live by the acronyms.
But
you're using acronyms that I am not familiar with. What's
no, that's
an
my fault.
IOP?
So a substance abuse intensive outpatient. It's a particular Medicaid-funded program where you have to do 9 hours a group a week, and then you get some case management, some other supports around it. And so, you know, especially during the pandemic, groups have been hard, right, across the system. And so in some areas, we've seen those IOPs drop back, and they've done a lot more individual over telehealth with those individuals. Some places we've been able to do some group via telehealth, as you know, because of social distancing and other things. That has created a hamper providing those services across the system. But all of our contracts, even for Alleghany County, requires that there be an intensive outpatient substance abuse group in this county. And so that is something we can go back today, Mark, and we can see, okay, we're coming out of the pandemic, we're moving into a different space, and we can assure that that IOP, that intensive outpatient group, is available and it's being accessed in the county. I think one thing that as a community, we have to continue to talk about these issues that you talked about, because one of the biggest challenges we see in our rural counties is connecting people to the right services. So you may see those transients, but those transients, even though we go out and we pay someone $500,000 to have that service available, they're not getting connected. And so I could come back to you next week and I could show you a list of the services in Alleghany County and how many people actually receive that service. And it'd be quite small. You may say like, well, we have a huge substance abuse need in Alleghany County. Why did only 10 people go to that group? And why did VIA have to subsidize all these dollars just to keep that service in place in a rural county? Because that's what we do to guarantee that's in a county. We have issues in a lot of our counties is we pay extra to keep those services in the county, but people are not getting connected at the group level in order to, one, allow us to grow those services to meet the needs, and for those people to really get the services and the supports they need. I looked at the Daymark walk-in data on the way over here. Wasn't able to get it in my slideshow because I wanted to see if somebody walks into their program, how quickly does it take before somebody actually sees them and does something with them? We track that. with all of our programs. And for the Alleghany Center here is from the time somebody walks into the door to the time a therapist sees them is average 24 minutes.
That's without an appointment.
Without an appointment. They just walk in. So if the lady off the street with their suitcase was at the Daymark and they brought her in, they're seeing people within 24 minutes of walking to the door. That may be telehealth, may be a real individual on how they're doing that, but they're seeing that. And so with that, to me, that's a data point where it's not like they're being overwhelmed, that they don't have enough capacity in the system. To me, it's a conversation. It's not just us. It's not just you. It's us sitting down with all of our local community and our stakeholders to see where is the system breaking down for that individual and these transients not being connected to the right services and supports. And when you have those conversations, you're going to identify some holes in our system. Absolutely. We own it. But it allows us to then plug the holes the right way, because then you know that the sheriff is going to bring these people to X, or this community partners are going to connect these services to Y, and our system needs to be prepared for it. And I think that's one thing that I would just encourage us as a group to talk about as we go forward is, as not just building the services, it's connecting people to use those services.
Well, you've also, another disconnect is I know of 2 good private providers that just got so fed up with VIA that they threw in the towel. They said, I'm not going to see any Medicaid people anymore. I'm not going to deal with having to do the SNAP assessment and all that other stuff because it's not even worth the time or trouble for my billing rate. So you're losing out on good providers because of all the hoops that they have to jump through. They send something to VIA, it gets kicked back. They send it again, it gets kicked back over one little code or one little something, and they're just like, I'm done. I don't want to deal with it.
So I'll just mention that is there's a lot of bureaucracy in Medicaid, in the state system, that, again, we don't have too much control over. But what we have done is we have provided rural rate enhancements. And so if that provider would have came to us and said, hey, doing business in Alleghany County costs more than doing business in Charlotte or whatever, and I need a 10% increase on rates. We've done that all over the place in our catchment area to support rural counties. So I don't know exactly those 2 providers, but we are always looking for opportunities to support local and small providers through enhanced rates or whatever it takes to create that. We may not be able to reduce their paperwork because it's a state requirement, but we can try to pay them a little bit more because they're not able to be as efficient as a really large organization. And so if there's another opportunity to engage them, we are completely open to that conversation.
I did want to ask Commissioner Irwin, coming back to your concern, because we do know about the suicide rate in Alleghany County, and I think that's one of the things that, part of why we made sure things continued. If you guys, this is actually something, the mental health first aid and mental health first aid for youth is actually something that can be done by community, and it's probably one of the most effective things you can do, low cost. We have the trainers for it. It's really about getting the right people in the right room, and what they found is in communities where they do that and they really actively follow through on those trainings, you basically are mobilizing your whole community and suicide rates go down. So I think if you all want to do that in a more proactive way, if you have, I mean, we're here. Like we've got the training, we've got the resources to do it, we've got the team to do it. What we need is the support of getting connected to the right key leaders, whether it's in your school system, if you've got faith-based communities, if your churches are interested in supporting this and care about this. Like I know in my church they have, there's a big focus on mental health and supporting people on that on 2 sides. One is about, dealing with substance use because we know lots of people have been through it. It's not just those people, it's we people. And then the other one is on suicide because depression and all that's really real. So like they're invested and engaged in those things. If you've got teams or areas where we can support that, we can get the people to train it. We need to get the people in the room. Yes.
Rhonda, we've done a few things with Alleghany Lives, which is a really
Yeah.
big
Right.
organization. We had a screening, I think it was February 1st of 2020.
The ripple effect?
Saturday, me and Commissioner Evans hung out together, but 72 people, our largest screening.
Yes.
And we've done these in multiple counties, but you always don't, you don't necessarily have a lot of interest sometimes, or don't get people there, so we had a really great group come forward. We're more than
Well,
willing to do more of that.
You know, one thing that we've got to realize, and this community and this nation has got they're going to become very aware of it real quick. Right now, we have meth cut with fentanyl coming across the border in amounts that we have never seen. And that means supply and demand. The supply is there, demand is there, and the cost is going to go down. You talk about walk-ins. Now let's put ugly on the table. When someone walks in, they finally reach the point where they know they either change or die. But that's about 1 in 10. About 10% is going to turn themselves in, and eventually that other 90%, and it's the same thing with alcohol, is going to die of their addiction. So this is going to be a problem, and with the meth and fentanyl that's coming in right now, the cocaine that's coming across the border, it is here. Alleghany County, Dobson and Galax are two of MS-13's major distribution areas, courtesy of Interstate 77. It's here, it's going to be here, and it's going to hit us. And you know, you can do everything that you want, but frankly, you could double your services, and I doubt if you really meet the need. There's only so much you can do, I realize that. There comes a point whenever you realize that you've just got to say, this is what we can do, we will do it to the max, we will do it to the best of our ability, and there's going to be some that's going to fall by the wayside. Sad, but it's true. Thank you for your presentation and for what you do.
Thank you. I
Any
think
further questions? Anybody over here?
A question, but I would offer that I think one of the big challenges is meeting the need with the services and helping the folks wade through that in our community. And I think we could all work to try to improve that to somehow, and hopefully, you know, create some kind of a plan or an initiative, I think, to try to match some of these things up.
I think if we could get people in the door, I think there are services here. And actually, one of the things that ensures that you have or specifically intensive outpatient for substance abuse treatment, that's one is a volume issue. So you have to have people that have, the more people that you have, actually, the better that is, because it can support a program more effectively and keep it more stable. I think, to your point, we're open. Brian's here a lot, I think, but we're open to doing this. We do this in most counties. A lot of the initiatives that you saw were a little county saying, hey, we've got a gap, and we need some help. Or maybe you have it, but we're not getting people in the door. And it's just figuring out, it's hard work, but you just sit down and you just figure out what are the logistics that it's going to take to get people to know where they need to go. If it's not working the way it's supposed to, we need to know that. That's our job to fix that, and we will. And again, it won't happen tomorrow, but it's going to, I promise you there'll be somebody on the phone probably this evening about it. And I think it's just staying connected with is it working? Where else do we need to shore up? If we, and is it like whack-a-mole? You hit one and then, another one pops up somewhere else, which it is. I mean, guys, these are humans. There's always going to be something, community, county government, you know how this is. So I think we're here to engage with you and to try to make it work and to try to figure the hard things out. There are limitations, Commissioner Irwin, to your point, but there's also a lot of creativity, and there's a lot of things you can do. And I think one of the things that I love about working in the West, and the reason I've stayed at VIA versus other places for so long, is we can make a difference here. It is one county at a time. It is one family at a time sometimes. It is slow and it is hard, but it's not like help's coming from Raleigh. So we have to figure it out, and we do. And I think we're very willing to do that if we know what you need and you tell us where we need to focus that attention. And I'm really okay with being accountable. I hope you haven't felt like you've gotten the bureaucratic two-step. I mean, some of it's not okay if that's what your experience is. That needs to get fixed. So I'll shut up here and let Brian close us out, I guess.
Well, I just wanted to ask the chairman if it was agreeable to everyone, and Commissioner Luffman, I want to get together and make sure my notes, I was trying to feverishly take them, I want to make sure we didn't miss anything. If, the 1st of June or, in 3 or 4 weeks or next week, whenever you wanted to, let's come back, look at the list, let Donald bring additional data to be able to answer some of your questions, and then let's just talk about plans. How can we address some of those things? Maybe there's a few things that, we can't do things about, but we're going to work really hard to make sure that we can confirm, make sure we heard you, and that you're not just going away thinking, what are they going to do with that list they were writing? We want to make sure we come back and say, hey, here's what we can do for you, and do a check-in. And if you think of more things then, put them on your list or call me, whatever you want to do. We just want to make sure we close the loop and make that commitment to you.
Certainly so. Bob?
I do have one question. With John's comment about this lady, it could be anybody, a man, whatever, was here for 2 weeks. Where was the breakdown why didn't that person get help? Was it the sheriff, town police? How was that person supposed to go to Daymart and get help? That person's not going to go to Daymart on their own. So, I don't see that as a failure of Daymart. I don't see that as a failure of VIA. How do we connect those people? If we see them walking up and down the street, do we call the police department and tell them? For 2 weeks, somebody should have noticed.
Well, actually, what was happening, people were calling dispatch. And by the
Why
time
didn't
they
she
got
go
to
to
where
Daymart?
her location was, she had moved somewhere else. She was sleeping in abandoned houses. They think that she was spending time with people that would pick her up on the street, but she was a mobile target. And whenever they finally did get her, the commitment requirements in the state of North Carolina apparently are a bear. She was, I believe she was from Canada, if memory serves me correct.
That would have been a tough one to fix.
But,
Yes, sir.
she was just a crack whore that had finally become so diseased that they put her out on the street first location. And as I said, Dobson and Galax are 2 major distribution points.
Yeah, but I go
That's it.
back to how do we connect these people to get the help that is there if they can get seen in 24 minutes or less?
Well,
It doesn't take that long
but on this situation, it would have been an involuntary commitment. The police would have to find her. They would have to assess her, and then it's go over to the emergency room to make the determination.
Yeah,
It's
but
an involuntary
If
commitment.
she's walking up and down the street, you said for 2 weeks, using language and pulling her
Yeah.
suitcase
Suitcase.
with her, somebody could have found her. I would have thought.
Yeah, I know in some of our communities, I'm not sure it's, necessary to fix in Alleghany, but it could be, we use homeless outreach programs. So depending on the volume. Depending on what the volume is, if your transient population's that high, maybe it would support.
Well,
Someone that does homeless outreach is going out and connecting those people. So, we have options that we can employ. It's just like, what's the volume? You wouldn't want to pay for a homeless outreach person to sit around and wait for one person every other month. That would be a big
In this
issue.
case, I called dispatch, and their response was, where is she? We've been looking for her. See the police car coming, by the time they get down there, she's somewhere else. Of course, she was walking down the middle of the road at the time, so.
And that's typical. We have transient populations, it's all across. We're able to track these individuals through our HMIS database. You know, Commissioner Luckman, you're probably very familiar with that. So we can see that this person was in Charlotte 3 weeks ago, they were in Lynn, but we have to get, you have to have the resources to that. You know, if you want to address, if the homeless population's that big in this county, then that could potentially be a service that we can employ, and do more outreach and engagement type levels. And that's what I'm saying is we can build the services, but maybe building the connection to those services is the first things we do. And then as those people come into services, we can track where they need to go, what services support, make sure that we're building the right services and supports to meet the community's needs.
We're certainly welcome to the meeting. This
So,
assistant clerk can reach out to you guys, and we get that set up, and we'll have some more conversation. And appreciate you guys coming. It's been very educational day and informative. It's been a good presentation.
I appreciate you guys letting.
Right.
if it's a member case, you wouldn't believe the calls I get. Member cases, your neighbor can't get into treatment, or just some big issue. Feel free to reach out, and let us know. Drew knows how to get a hold of anybody, and she's good at that. She can tell us where to be and what to do, so we appreciate your time so much.
Thank y'all.
Yep, thank you.
Thank you. Thank you.
Wait, I had a motion to close the work session.
We have another item on the agenda. do we not?
He left.
We don't have another item on the agenda?
City left.
We had one, but time's running out. Meeting, work session adjourned.